Hello, and welcome to our program, Staying Ahead, Anticipating and Managing Toxicity for BCMA-directed Therapy Adverse Effect Profile and Management. This is a CME program and is supported by educational grants from Janssen Biotech and Pfizer. I'm Dr. Nina Shah, and I'm joined today by my colleagues, Dr. Joseph Mikhael and Dr. Luciano Costa.
Hello, my name is Dr. Joseph Mikhael. I'm a professor at the Translational Genomics Research Institute in Phoenix, Arizona, and the Chief Medical Officer of the International Myeloma Foundation.
Hi, my name is Luciano Costa. I'm a myeloma physician and a professor of medicine at the University of Alabama at Birmingham. Glad to join Dr. Shah and Dr. Mikhael today.
Thank you. So exciting to have you guys here. And I think it's going to be a really exciting discussion. Here you can see our disclosures that are shown on your screen. Our program today is the second of two events about BCMA-directed therapies for multiple myeloma. So if you missed our first broadcast, you can watch them at BonemCE's Twitter page and check out our tutorials posted on mine and BonemCE Twitter pages as well. So over the course of our discussion today, we'll be addressing the following learning objectives: comparing clinical trial design, participants, and outcomes of BCMA-directed therapies, and identifying management strategies for anticipated adverse events of BCMA-directed therapies for different classes of therapy. So when we think about multiple myeloma and the multiple factors that affect treatment decisions, there are many. Now, we know that 40% of patients, this is based on real-world evidence, they do not meet criteria for inclusion in a phase 3 clinical trial. Now, this is important to know because we think about how we function with patients in the real world. We have to think about all of our patients, not just the ones that we're seeing in a clinical trial. Now, of course, that means that those patients might be subject to lesser overall survival and lesser progression-free survival than those patients that were actually enrolled in the clinical trials. Now, there's so many things that you think about when you think about what to do with the patient in this particular setting. It's like patient preferences, what they've had before and how they tolerated it. So treatment-related toxicity. We think about disease symptom and control, very important factors of quality of life as well, how convenient it is, which can affect quality of life, access to care, which may be logistic related or maybe where the patient is, financial toxicity, which is something we all are subject to, but often don't talk about, work productivity, which also is connected to the patient's sense of self and quality of life, as well as their physical activity and their own comorbidities as they come into the treatment. These are all important factors that we think about, and we want to make sure that we try to minimize them as much as possible. And we particularly think about what's going to happen with treatment-related toxicity as we lead patients into this next phase of their myeloma journey. Now, here we can see some key adverse events that have been associated with ide-cel and cilta-cel, and they appear similar. So it's good for us to see these because we know that whatever product we pick will probably have similar outcomes. So let's talk about some of the hematologic toxicities for these particular agents. Now, you can see here the neutropenia is almost always present, and that's something that we're used to for all therapies for multiple myeloma. So no surprise here, somewhere between 90 and 96% of patients have neutropenia, and it can be grade 3 or 4. Again, generally manageable. And I would say that some of us have used growth factor in the past, and we talk about this a little bit later in the discussion. Anemia is also there, as well as thrombocytopenia and lymphopenia. Now, what happens at 1 month? You can see here that the two lines that are most affected tend to be the platelets and the white count. So there is some neutropenia and thrombocytopenia still present at that 1 month mark. We talk about non-hematologic toxicities. I think probably the ones that we think about the most are cytokine release syndrome, also known as CRS, which is sort of a systemic inflammatory reaction. And this is very common in CAR T-cell therapy. As you can see for ide-cel as well as cilta-cel, this happens in 84% and 95% of patients respectively. One thing that's really interesting about the CRS for these particular agents is that it tends to be grade 1 and 2. There's very few grade 3 or 4 events in either of these trials for ide-cel or cilta-cel for CRS, and that's actually very reassuring, and it's something else we'll talk about as far as management. Now, neurotoxicity, what we generally refer to as something going wrong with cognition, or confusion or concentration. There are sort of two flavors of it. So neurotoxicity in general, we think about ICANS, which is the immune cell effector associated neurotoxicity. That's a definition that was sort of brought after these trials were conducted. But you can see here that in general, 18% of patients in ide-cel had neurotoxicity of any sort, although not broken down by ICANS or other. Now, when you look at cilta-cel, 21% of patients had neurotoxicity, and they did break this down into ICANS as 17% and other neurotoxicities is 12%. So just looking at ide-cel for a second, you can see that the neurotoxicities were generally grade 1 and 2. They had a few grade 3 or 4. And of course, in general, this is low at 18%. Similarly, at cilta-cel, if you look at neurotoxicity in general, they tended to be more grade 1 and 2. But since we were able to get a little more data from cilta-cel, you can see that there's a breakdown between what we'd call classic ICANS and other neurotoxicities. These included things like Parkinsonian disorder or cognitive or motor cognition disorders that happen for patients. Most patients recovered, but you can see here that there were a smattering of patients that had grade 3 or 4 outcomes here for the other neurotoxicity, and at least one patient who did not recover. So just a little bit different profile between the cilta-cel and the ide-cel product, where you have a little bit more non-specific, or I should say non-ICANS neurotoxicity in cilta-cel versus ide-cel. This is one of the differentiating factors, I think. Now, when we look at infection, this is also a very important toxicity we think about, and almost all patients are subject to it because, of course, we all have cytopenias in these patients. So about 70% and 58% respectively of patients had ide-cel and cilta-cel associated infection. Generally, these are grade 1 and 2, but of course, there were some grade 3 or 4 events, very similar between the two, 22 and 20%, something that I think we're pretty used to for these particular patients. Now, when you think about how you map out what's going to happen on the patient's journey, you can see that patients may present with symptoms of CRS, ICANS, or both. So they don't have to necessarily be one and then the other, but we tend to see a pattern where the CAR T-cell infusion happens and then we'll see CRS. Now, ide-cel CRS tends to be a little bit earlier, and median time to onset is 1 day versus cilta-cel median time was 7 days. And thereafter, you may see symptoms of ICANS. Now, it doesn't have to be after CRS or concordant with CRS, but the pattern generally does fall a little bit after that. You have to look to make sure you're looking for both. A lot of vital sign management to look at CRS, which can present with fever, tachycardia, hypoxia, really any symptom. But I would say fever is the hallmark of CRS and gets you to that grade 1. When there's other vital sign instability, for example, hypotension or hypoxia, you can get to grade 2. And we'll talk about that as well. The ICANS tends to be, as I said, a little bit after that, but can occur independent. So it's really important to continue to do the assessment for that as well. So when we think about using a tool in general to grade ICANS, we have the ICE tool. This ICE tool I actually find very useful and I think very pertinent to what's going on with CAR T-cell therapy, because it is this inflammatory reaction which causes something different than you would think of as general neurotoxicity. It really is this confusion, difficulty concentrating, difficulty writing and recollecting. And that is very well assessed by this ICE tool, which looks at orientation, naming, the ability to follow commands, writing, and attention. And with each of these tasks, and actually this takes very little time to conduct, and our nursing staff actually does this on a twice daily basis, you can get points for these. And you want to make sure that the patient is able to accomplish all of these tasks. And you can actually attribute an ICANS grade based on the score alone. Now, there's the ICE tool for the score, but there's also ICANS symptoms like aphasia, cognitive skill impairment, confusion, et cetera, which play into the grading. But when you think about just that ICE tool, that tool itself can help you get the grade. So if a patient has answered all of those and seems to be having no neurocognitive symptoms, that person would be grade 0 or not have any ICANS. But if they have a score of 7 to 9, they would be grade 1, 3 to 6, grade 2, 0 to 2, grade 3, and 0, the patient would have grade 4 ICANS by definition. So what do we do with these toxicities? The good news is we've learned to manage them over time. And I really am so happy that we've been able to have clinical trials with a lot of patients enrolled, these very interesting and important pivotal trials that have not only given us efficacy information, but have also given us information on how to manage these patients. So for patients with grade 1 CRS, remember I told you that fever is the hallmark of this. Those patients can either be managed very conservatively, or they can be managed with acetaminophen, or they may be able to be managed with tocilizumab if it's early onset. Grade 2 CRS requires fever and vital sign instability, which might include low blood pressure, which does respond to fluids, or hypoxia. And for those patients, things like tocilizumab and dexamethasone should be considered. Grade 3 CRS has the requirement for vasopressors and requiring high flow nasal cannula. And those patients, again, should be treated with supportive care and also tocilizumab, dexamethasone. And of course, grade 4 CRS, this is fever as well as severe hypotension, hypoxia requiring mechanical ventilation, et cetera. Those patients may get tocilizumab and potentially higher dose steroids, potentially also with alternative therapy, which can be cytotoxic therapy as well. Looking at how to treat ICANS, I would say that the hallmark of treating ICANS, first of all, is to identify it. So this ICE score is very important. So patients that have a mild ICE score of 7 to 9, they would be considered grade 1. You can consider either just supportive care and very close monitoring, aspiration precautions, or you can consider treatment. For example, you can consider tocilizumab, but we tend to use steroids first in these particular cases. Again, as the score goes on, ICE score 3 to 6 automatically gets you a grade 2 ICANS. Again, those patients are a little bit less arousable, but they do awaken to voice. Again, you can consider dexamethasone, then going on down. Grade 3 ICANS, those patients really have a lower score, definitely need dexamethasone or methylprednisolone. And then grade 4 ICANS, those patients may be in a stupor or coma, have a life-threatening seizure. Those patients definitely should get methylprednisolone high dose. And then you can consider increasing that if necessary. Remember, at all of these steps, you should consider things like preventative and supportive care. For example, anti-seizure medications as a start. We often actually give them anyway in a prophylactic matter to prevent potential seizures that might be associated with ICANS. So if you see that these toxicities occur, we also know that there's a way to mitigate them, and a REMS requirement has been put in place for both ide-cel and cilta-cel. And the purpose of these is to really, as the title would suggest, mitigate the risk of these particular agents. So you want to educate the patients, train and ensure staff that are aware of how to manage the risks of cytokine release syndrome and neurologic toxicities. They know how to identify it. They know how to document what's going on. In addition, they need to have access to 2 doses of tocilizumab on site for these patients to be getting these treatments. We have to ensure that these agents are given in an approved setting. So there's a specially certified center, and they're around the United States, and you can look them up. And these centers have been trained and have experience with this particular delivery of care. And of course, most importantly, educating not only providers, but patients and their caregivers, providing patients with wallet cards that explain CRS as well as neurotoxicity. So these are all important things that we want to make sure that we give to our patients as far as making sure that we can mitigate the risk as much as possible. So I want to move on now to a case, and we'll bring in some of our colleagues here. So this is a 66-year-old African-American female who initially presented with fatigue, anemia, had a pretty good performance status, ultimately was diagnosed with multiple myeloma, ISS stage 2, Dury-Salmon 3A, with the translocation 1114. She did have normal renal and hepatic function, was given initially bortezomib, len, and dex, got a transplant, and then got lenalidomide maintenance therapy, did have progression, so went on to receive daratumumab, pomalidomide, dexamethasone, as well as then thereafter carfilzomib, cyclophosphamide, dexamethasone, then elotuzumab, pomalidomide, dexamethasone. Unfortunately, progressed after that, but then was ultimately able to get cilta-cel. So this patient got fludarabine and cyclophosphamide lymphodepletion, as is the standard with CAR T-cell therapy for multiple myeloma, and then had an infusion. Now, I want to make a point about supportive care that we give these patients, and really in an effort to prevent infections and other complications that happen after CAR T-cell therapy, which we just saw on the slide. This is very common. So this patient did get vaccinated for both influenza and COVID before, although now we know that we probably have to support these patients afterwards since they do have B-cell aplasia. We also do give antiviral and pneumocystis, as well as antifungal prophylaxis, and this helps as the patients have lower counts as they proceed to get their CAR T-cell cell therapy. So this patient got all of those, got her cilta-cel. Now, 1 week after receiving the CAR T infusion, she had developed fever and hypotension that did not require vasopressors. On exam, she does have disorientation to time and place and difficulty writing a sentence and counting backwards, and was therefore diagnosed with both grade 2 CRS as well as ICANS. Before we go on to that, I just want to make sure that you know that all of these patients go on to baseline testing beforehand. So we are able to make sure that we adequately understand what their risk is of having all of these done. Not only do they have baseline labs, which this patient had, we also have some imaging that's done if there's any concern for CNS myeloma. And finally, what we do a lot of times is to make sure that the patient has had an assessment. For example, if we do geriatric assessments, we do include them as well. So I want to talk a little bit about this grade 2 CRS as well as ICANS, and talk about maybe how the patient would be managed, and maybe bring in our expert panel. What do you think about how you would manage this particular patient with this grade 2 CRS, and what you would have treated the patient with?
Thanks, Nina. That's actually a really important question, a really important issue in this patient. We are getting better at both recognizing and intervening for cytokine release syndrome. And it's become important to us. In fact, I think the trend is going to be even earlier and earlier intervention as we go through. But for grade 2 CRS and this patient, there's no doubt the patient should receive tocilizumab and should receive a dexamethasone PRN based on their hypotension. This patient needs to be watched closely because we don't want to cross that threshold into grade 3, because that's really where there is that big drop off, as it were, in terms of the degree of management engagement that we require. When a patient gets to grade 3, that's when they're going to start to need vasopressors. Very often by that point, we're taking them in to more intense settings like an ICU or a step down unit. And so this is where hopefully we've been anticipating this coming, deciding whether or not we would introduce TOSI. But in this patient, I would definitely be using TOSI and dexamethasone PRN.
Everybody, no matter how experienced anybody can be on CAR T cell, we're still at the beginning of the learning curve, because it's very new therapy, very new technology. And I remember setting up the RAMs for the lymphoma CAR T trials just a few years ago, and how much things have changed. I think there was initially a very high concern that steroids would kill the CAR T and would be the end of it all. And I think over time we have become much more comfortable deploying, tocilizumab, deploying steroid and deploying other, let's call third line agent. I totally agree with Nina and Joe. In a case like this, with CRS and already ICANS, we certainly do the TOSI to address particularly the CRS, and then go with steroids to address both, but particularly the neurotoxicity.
Yeah, I think as time has gone on, I've also become much more aggressive in managing CRS and neurotox. And exactly as you said, Luciano, we now know that we are not making an adverse outcome worse, or that we're making efficacy worse by giving these treatments. So in this situation, with grade 2 CRS, I definitely would jump on the tocilizumab, and I would actually give the tocilizumab and the dexamethasone at the same time. I tend to think about CRS, and the first thing I do there is the tocilizumab, and I often give it even with grade 1 CRS if there's been early onset grade 1, for example, in the first 72 hours. In addition, any neurotoxicity makes me worried, right? Because you don't want it to progress to something like a seizure or something there they can't protect their airway. So I tend to be also very quick with the steroids as well. Particularly, for sure, this person had grade 2 CRS, grade 2 ICANS. I definitely would be giving steroids. And one of the keys here, I think, is to not just give the steroids for just a dose or two, but you really need to give them a few doses because you want to make sure you don't just turn it off and then it comes back on again, has a sort of rebound inflammation effect. So I really do think that both of these would be important for the management of this. I wanted to kind of think about, we now know that cilta-cel was recently approved, yay. And I want to get your idea about how similar or different these agents are with respect to toxicity. And I know, Luciano, you have experience with this. I want you to start about telling us what your experience has been about these two products, or what your knowledge is about the differences in the toxicities of these two products.
One thing is interesting, we observe the clinical trial data, but oftentimes when you get to practice, there's that bedside day-by-day feeling that sometimes matches, sometimes it doesn't. Of course, we don't have that kind of real-world cilta-cel experience yet. All we have had is from clinical trials. But I think looking across trials is, just like you described, Nina, I think the CRS is very similar in terms of incidence and severity. And the main difference is timing. And I think that's very important. If I'm treating a patient with cilta-cel and by day 7, everything's fine. If the patient is in an inpatient setting, which is often the case, we'll start thinking about discharge. And a cilta-cel patient is probably going to be different. I mean, maybe a patient that you're more prompt to even start outpatient because things don't seem to get problematic when they do until much later on. So it has those practical implications. I think a lot has been made about some sudden differences in neurotoxicity. I mean, the rate was higher with cilta-cel when you compare the KARMA study with the CARTITUDE-1 study. But we all know over a very short period of time, those things have evolved in how they are reported from trial to trial. Things are reported, coded different. I think we need to see more, to get more experience, really more data. To at this point, I would not make that a defining factor in any particular way.
Yeah, what about you, Joe? What do you think about the difference between these two products as far as toxicity goes?
So, of course, it's really tough to make detailed comparisons because we haven't, if you will, been treating patients head to head at the same time, although we've been participating in these trials. I think one of the really important messages here is to understand that they are similar in terms of what the T cell process invokes in the patients, where we do see classically the cytokine release syndrome, the neurotoxicities, and the cytopenias as sort of being the big three that we have to watch for. But the differences between them are considerable, whereas with cilta-cel, we are seeing a later emergence of the CRS as opposed to ide-cel, where we're seeing that CRS earlier on. And so that's going to influence with time, how we are monitoring these patients, even when we admit them or not admit them. Do we admit them initially for the ide-cel product or the cilta-cel product and then bring them back and just obviously be monitoring them as an outpatient, bring them back when the CRS might spike? I mean, these are things that we're going to have to learn with time. I think overall, the principles of management of CRS are going to remain the same. With respect to neurotoxicities, I think we perhaps may see them a little bit more prominently with the cilta-cel product. But again, as you've indicated, Nina, as we've all been trained and are training our staff to be able to recognize these things and ask the right questions to detect them, then we'll be able to anticipate them and intervene in the right way.
Yeah, those are all really important points that both of you made. There are differences between ide-cel and cilta-cel, but the most important thing that we have to do is find them or find any of the toxicities. We have to anticipate them. That means educating ourselves, the providers, the nursing staff, and the patients, because oftentimes, especially with neurotoxicity, the caregiver is the first one to make the note that something is not right with their spouse or their family member. So all decks, all hands on deck as far as trying to make sure that all of us are educated, either the provider or the recipient or their team members, their care team members. And I think that will ultimately help us to manage these toxicities the best, which is great. So I want to move on to our next topic. And for this, I'd like to introduce my esteemed colleague, Dr. Luciano Costa, to go on to topic number 2.
Thanks, Dr. Shah. I'm going to discuss a little bit about the toxicity and the side effects associated with the bispecific antibodies directed at BCMA. Contrary to what we have with CAR T-cell, now that we have 2 products available, one made available as recent as this week, with bispecifics, we don't have yet any FDA-approved BCMA bispecific. However, there is a parade of agents being in clinical trials, and we expect that at least one or more will be available, if we're lucky, before the end of the year. They have many of the toxicity that Dr. Shah just discussed when talking about CAR T-cell. And a lot of the parameters in our guidance for management really mirror what was established for CAR T-cell. And you can see why. I mean, if you see the neutropenia is not dissimilar to what we see with CAR T-cell, including grade 3 and grade 4 neutropenia. One thing is important. My practical observation is the neutropenia, and the same goes for the thrombocytopenia, It's not like with CAR T cell that they have one long phase and they tend to resolve, sometimes with a second dive. Here it seems to be very cyclic, sometimes related to the dose, and it's very easily addressable with growth factors when needed. So we often watch those patients when they dive, particularly below 500, we tend to be a growth factor, and they tend to respond very well. The same goes for thrombocytopenia. Anemia is also common, and so is lymphopenia. Cytokine release syndrome, if you look at the rate, it looks somewhat similar to CAR T cell. It changes a little bit from product to product, but we got to keep in mind the numbers are small, and I think it's way too premature to try to compare different T cell engagers in terms of CRS rate. But the rate of grade 3 and 4 is exquisitely low. In many of those trials, is as low as 0%. And that doesn't mean that bispecifics are less active or they're doing less engagement than the CAR T cell. What that means is here, different from CAR T cell, the dosing of the agent is the limiting step on the reaction. And many of those bispecifics have been worked out that you can use sometimes a subcutaneous dose to have a more gradual phasing of that reaction, or you have a step-up dose so that you have the opportunity to mitigate the CRS when it happens at a lower dose and address it and prevent it from happening with greater severity at the later dose. Hypogammaglobulinemia and infections are also quite common. And until those agents move to early lines of therapy and we do comparative trials, it's really impossible to discern whether those are result of the therapy itself, the underlying disease, or really how late those patients are, because those patients are coming to those therapies after, in average 5 to 6 lines of therapy. They already had a very depleted immune system, in lack of better word. Hypogammaglobulinemia is almost a fixture. All those agents target BCMA that is present not only on the malignant plasma cells, but also on the normal plasma cells, and they will cause a hypogammaglobulinemia. And that often can be mitigated by, particularly in patients who have a history of recurrent infection, by the administration of IVIG. 2 other bispecifics are also in study, elranatamab and CC-93269. We have somewhat lower numbers, but what appears to be a higher rate of CRS. This is probably premature. Those are smaller, sometimes earlier studies, and we really need to see follow-up of those studies with more patients to see what that rate stays at. The other problem that we see, other than the CRS, is neurotoxicity. Fortunately, neurotoxicity with bispecific has been extremely rare. And for the most part, we tend to apply the same principles that we have learned from and having been outlined for the neurotoxicity after CAR T cell. As I mentioned before, a problem not specific to this therapy, but also to the myeloma population is the risk of infection. And as you can see here, the risk of infection is anywhere from 55 to 70% across different studies for both bispecific and CAR T cell, and grade 3 or higher, anywhere between 20 and 35%. Again, it's tempting to compare across those trials, but remember, those have different duration of follow-up, a slightly different population. What can we do about it? We have to be prepared and do everything we can preventively, so make sure that our patients stay immunized. Those are the patients I always give a hard time, make sure they got their influenza immunization, make sure they got every single allowable dose of COVID vaccination. We do universal antiviral prophylaxis for our myeloma patients. They may be a little bit extreme, but everybody is on VZV prophylaxis. And we certainly make sure that patients remain compliant if they go to therapy such as CAR T cell or BCMA-directed T cell engagers. Pneumocystis prophylaxis is not something that is universally done in multiple myeloma. It's more a fixture of ALL type of therapy. But those patients oftentimes have very low CD4 count, and infections with pneumocystis jirovecii have been reported on those patients. So we use pneumococcus prophylaxis on essentially everybody. Antifungal prophylaxis is not universally done, but particularly patients who need to be on steroid for a long period of time. And last but not least is IVIG. Those patients are going to be hypogammaglobulinemic, essentially all of them. And not all of those patients develop infections, surprisingly. We all have patients who have hypogammaglobulinemia for a long period of time without having recurrent sinopulmonary infections. But I have a very low threshold. I don't wait for a second pneumonia to initiate those patients on IVIG. And that potentially can help reduce that risk.
Great. That was a really nice overview of bispecific therapy for multiple myeloma. And I agree that it's one of these things that we're really looking forward to for approval, but maybe our understanding of what the toxicities are with CAR T-cell therapy is going to help us to manage, prevent, and hopefully have a better experience. Now, they are different, and I want to kind of bring this into discussion with the two of you, because we have CAR T-cell therapy. We know that it causes CRS and ICANS, and that is why there is inpatient management at a big academic center, or there's a requirement for a big academic center to be involved. And I think just the logistics alone of getting the T-cells collected, et cetera, does make this happen to be at a specialized center. And as we talked about in the REMS program, one of the parts of that REMS program is that it has to be approved centers that give this particular therapy, particularly CAR T-cell therapy. So now, thinking about bispecific antibodies, are we going to be able to bring them directly into the clinic because we have lower rates of CRS? What do you see as the pathway for these therapies to be used? Are they going to be first inpatient, outpatient, first academic, and then community? I'd like to hear about both of those dimensions as far as thinking about the side effects and CRS and what you think are the differences. So maybe we'll start with Joe. What do you think about the differences between CRS, ICANS percentages for CAR versus bispecifics, and what that means about where they'll be first given?
So, Nina, you're asking the critical question, of course, here, right? I mean, biologically, the T cells are kind of doing the same thing, as it were. So we actually see a very similar profile of a toxicity with the cytokine release system and neurotoxicities, but really at a much very different scale, meaning with CAR T significantly more dramatic, and with the bispecifics much less. So in many of our bispecific studies, we're seeing none or very, very little grade 3, and in fact, mostly grade 1 CRS. And this is a critical point. I think it's obviously related to the T cell burden as to how many T cells are engaged on an ongoing basis versus that one big blast that we have with CAR T. But it has a huge implication as to what we're ultimately going to be able to do in terms of patients' admission in and out of hospital. Right now, we're giving everything inpatient initially, and then moving hopefully towards an outpatient setting for the patients who have bispecifics. And we're still, mostly speaking, doing CAR Ts as an inpatient. So similar profile, just more dramatic in the CAR Ts than with the bispecifics.
So you think that we'd probably start out in a specialized center or inpatient, then move to the clinic, yes?
I think you're right for bispecifics. That's what we're going to be doing. Now, could there be an opportunity with time to do it all as an outpatient? I think as we recognize and intervene for CRS earlier, and maybe even with newer products, as you know, with natural killer cell engagers, they may have less CRS. But I think right now, likely for the short term, we are still going to absolutely be admitting patients for at least their first, if not first 2 doses of a bispecific therapy, and then doing the rest as an outpatient.
Yeah. So Luciano, speaking of how this is going to be managed, there's a REMS program for CAR T-cell therapy. You know that, and I gave you the 4 sort of pillars of that. How do you think it's going to be different for bispecifics, especially because of that one part of the have to be a specialized center? What do you think we can anticipate for the REMS program, if there is even one, for the bispecific engagers?
No, I think I totally agree with the points that Joe made, and I would be shocked if the bispecifics come out without a RAMS program. But the crucial difference here is, a specialized center is a center that did the training and has the personnel. I don't think it's like CAR T-cell that you have to be a cellular therapy site. I think that's be one crucial difference. I don't see CAR T being given anywhere other than a center that is established as a cellular therapy place because of, not only the safety, the expertise, but also the regulatory requirements that are involved. Really, I see bispecific much closer to monoclonal antibodies than with CAR T in terms of logistics, in terms of phasing in terms of challenges. And the point that Joe made is crucial. I mean, beyond the first half of the first cycle for any of those agents, we just don't see CRS. It's just the nature of it. And then I have patients on bispecific for like 3 years now. It's the easiest, quickest visit. They're in infusion for 30 minutes and they're gone. And I think that really something that the community can do. I totally agree. I think the analogy of the CD38 monoclonal antibody is not an exaggeration. I mean, at some point, we're doing the first doses and they're continuing on their home offices with the community oncologists. And I think we have, we can look, there's a culture of a little bit of, we could call academic arrogance, that we think that we know something that the community oncologists never don't know. But actually, they have become very accustomed to immunotherapy. Remember, immunotherapy is mainstream of, some of the most common cancers nowadays. So I totally can see a scenario where those drugs are administered routinely in the community.
Yeah, I think you bring up a lot of really good points. We're in this sort of myeloma silo. That's all we see and treat, but a lot of different practitioners have been managing pembrolizumab, et cetera, some other immunotherapies, blinatumomab, et cetera. So this is not an uncharted territory as far as immunotherapy goes. And I think when we think about the toxicities of T-cell therapy, there are clear differences, as you pointed out. There's not as much neurotoxicity with the bispecifics. And I think one of the things that is going to be interesting is there's two parts of this, right? So what happens initially, is it only at an academic center or not? And then secondly, is it only inpatient or not? And so those are sort of like two factors that you can think about. One of the things that is good about bispecifics is that they're dosed sequentially. So giving steroids in advance, for example, as a pre-medication for the first doses, and also treating CRS very quickly with toci and or steroids, you can imagine doing that because they're going to get another dose of that bispecific the next week or 3 weeks after that. So it's not just one and done with the CAR T cells as it was. So we had a little bit more fear about doing that, but I feel very able to give tocilizumab and steroids liberally for these particular cases, especially because now, as the step-up dosing was, you want that CRS to be done so that they can get the next dose. So a lot of us went on that route, and I think it was good that we had these experiences of the toxicities of the bispecifics, because now I do think there's a way to manage them as an outpatient, and I think we're going to see one day where we have an algorithm for things like teclistamab and all the other ones that you spoke of, where maybe the first time the patient has the fever, you immediately give a dose of tocilizumab if they're in the clinic or close by. But if it's after hours, they might take a dose of Dex at home, and then the next day come in and be evaluated, and then being completely transitioned to an outpatient management. So it'll depend on what the REMS says, but I'm looking forward to seeing if we can, as Joe said, have this so we can increase access for patients who cannot come to these inpatient large cities, et cetera, to get their care. So looking forward to that. All right, now I'll hand it back to Dr. Luciano Costa.
So I want to talk to you a little bit about ocular toxicity. That being the most concerning adverse event, I would say the signature toxicity of belantamab mafodotin. And you can see on this table that hematologic toxicity is common, but as Dr. Shah and Dr. Mikhael mentioned before, that's hardly ever what concerns us, because we're comfortable and familiar, and we have very successful and well-established strategies to manage neutropenia, anemia, thrombocytopenia, and so on. Infections are not rare, likely reflecting more of the population than anything else. But the thing that is unique about this agent is ocular toxicity. So as you can see on the pivotal DREAM2 trials, keratopathy was seen in 72% of the patients, and in 46, almost half the patients was grade 3 or higher. The change in the best corrected visual acuity was 54%, 31% grade 3 or higher. Blurry vision also happened, and then dry eye also happened, which really starts pointing out to one of the problems with sometimes things are called by the objective finding, like keratopathy. Sometimes they're graded by their symptoms, like blurry vision. And there is a scale for ocular toxicity. I have to confess, before being involved with belantamab mafodotin, I really never knew about it or really care about it because it's not part of what we do as hematologists, oncologists. But then we all had to get used with keratopathy and ocular toxicity grading. So the grade 1 is mild superficial keratopathy, something that the ophthalmology can see and is often asymptomatic. And the visual acuity, the best corrected visual acuity, declines by up to 1 line. And the recommendation in those cases is to continue the agent without any change in therapy. Those changes are considered minor. Grade 2, the patient now has some superficial keratopathy that is moderate, and the visual acuity has declined by 2 to 3 lines. And that's a pause. Those patients, we need to hold the belantamab mafodotin and continue the periodic eye exam until it improves to grade 1. And in that case, you can resume the belantamab mafodotin. Grade 3 ocular toxicity is when you have a severe superficial keratopathy or you have a decline of more than 3 lines. And of course, in those patients, we're also going to stop belantamab mafodotin, continue the periodic eye exams, and then resume if the patient is deriving clinical benefit, but at a reduced dose. And of course, we never want to get to that, but there's grade 4 ocular toxicity, where you have corneal defects such as ulcer. You have a decline in visual acuity down to 20 to 200 or less. And in those cases, you have to hold belantamab mafodotin, and you either discontinue permanently or resume much later on after the patient has improved to grade 1 or less, after a very careful discussion with the patient about the risk and benefit of resuming such therapy. So those modifications for ocular toxicity are common, but on the DREAM2 trial, discontinuation was rare. As I discussed before, near 3/4 of the patients had keratopathy. Some of them did, and some of them did not have visual changes. In 56%, there was some symptoms or meaningful decline in visual acuity. Half the patients had some delays in doses, omission of doses due to keratopathy, but only 1/4 required reduction, and very few, only 3%, had to permanently discontinue the drug due to ocular toxicity. Very much like CAR T-cell, there is also a REMS in place. When the FDA approved that product, it approved attached to a REMS program that have the same pillars that Dr. Shah mentioned before. First and foremost, educate everybody on the healthcare team that we know what we're getting into, we know the risks, and we know how to monitor those patients. We have to document. There's a necessity as a requirement to have an ocular exam done by a specialized ophthalmologist or optometrist before each dose of therapy, which is really something not overwhelming, but very new to our field. We're not used to work hand in hand with an ophthalmologist or optometrist. And we just saw why, because we have to rely on their grading of the keratopathy and the visual acuity in order to decide, does the patient get dose or does not get dose, or does the patient get dose or a reduced dose. And everybody who is involved on the care of that patient has to be trained, and only once the facility professionals have received training, that facility is considered authorized and can dispense the therapy. And last, but perhaps most important, is to educate the patient. None of those gradings are perfect, and sometimes you have huge disconnects between the ocular exam and how the patient feels and how that's affecting the patient's life. And it depends on their activity or what they're involved with or what they utilize the site for. They may have different tolerance to that toxicity. And that is very important. And we always tend to be conservative and take the most conservative approach, whether that is dictated by the objective finding or by the patient symptoms. We want to keep on the same topic of discussing management toxicity of those BCMA-directed agents. And we're going to pick up that very same patient that Dr. Shah presented early on, but now instead of getting a CAR T-cell therapy, she receives belantamab mafodotin, the anti-BCMA antibody drug conjugate, at a dose of 2.5 milligrams per kilogram every 3 weeks. And as part of the supportive care, this patient receives preservative-free lubricant, eye drops 4 times a day. We tell her to avoid contact lens unless directed by ophthalmologists. And she starts her therapy with belantamab mafodotin, and she achieves a partial response. However, she does go on to develop grade 3 keratopathy. So how do we go about managing toxicity on this patient? And with that, I'd like to turn back to Dr. Shah so we can have a discussion about that.
Yeah, thanks so much. Just a real brief discussion. I'll ask each one of you one question after that presentation or that bit of it. So first of all, how much of a barrier to therapy is this ocular toxicity in your opinion? So we'll go with Joe. What's your take on this?
It is really a genuine issue, Nina. It's an issue because, first of all, according to the REMS program, everybody has to see either an ophthalmologist or an optometrist prior to each dose. And at that visit, they have to have no more than a grade 1 keratopathy by virtue of a slit lamp exam and a visual acuity testing. So it's a barrier in terms of the logistics. Most of us, after a while, we've gotten accustomed to it, and we have some ophthalmologists and optometrists that we've been working with that are familiar with the form and the testing and can get it done relatively smoothly. Probably the bigger barrier, though, is not so much the logistic one, is just the patient's concern. I mean, who of us want to have our vision affected? And obviously, when we have limited options in myeloma, and this is a good option, it can be pursued, but it can be a concern to patients. We know from some of the surveys we've done that the majority of patients, the significant number of patients are concerned about driving and do experience some blurriness of vision. And so that has to be part of the very important discussion between the provider and the patient to know what their needs are, what their concerns are, so that there's no surprises when they go on to the therapy.
Yeah, those are all really, really good points. It is very patient dependent. And on the flip side, we have this ocular toxicity, but on the flip side, it is an off-the-shelf therapy. And Luciano, how does this off-the-shelf status influence the use of this drug?
Very much so, Dr. Shah. I think when you compare to the other agents, you don't have a need for hospitalization, you don't have CRS, you don't have neurotoxicity. And many times those patients who have received 4 or more lines of therapy, their disease is very rapidly evolving, and they just cannot afford, for example, the time that would take to manufacture a CAR T cell product, and the availability is not optimal either. So oftentimes that we make the choice is made for belantamab mafodotin based primarily on that prompt availability. And you can't deny that, that is really an asset, along with the convenience of being dosed once every 3 weeks.
Yeah, those are all really important points and something we should consider for patient access as well as treatment and balancing all of these factors. I want to turn it now over to Dr. Joe Mikhael for the next section in our discussion.
Thanks so much, Nina. It's a pleasure to talk about this aspect of myeloma therapy, which I think is actually so critically important. And of course, our patients would tell us that this is important. And let's start talking a little bit about quality of life. And, historically in our clinical trials, we focus so much on response rate, progression-free survival, overall survival. It's very encouraging to me now to see, as we're using these newer novel approaches, we're incorporating quality of life measures, usually as secondary objectives, but we're incorporating them into the clinical trials that we are participating in and that are so heavily influencing the field. So first of all, for belantamab mafodotin, we do have some data that even despite the ocular symptoms, the keratopathy that we can be so concerned about, we saw that patients' global health status, which is a measure of their quality of life, remained stable even when there were changes in their vision-related functioning. So I know there's lots of data here to go through, but one of the things we look for in this kind of situation when toxicity exists is, does a patient, if you will, maintain their quality of life? So we look at measures like their global health status, their overall physical functioning, their role functioning, and being able to do the things that they would typically want to be able to do. And so we see here that was really quite well maintained during the treatment, despite some of the challenges that may exist from a toxicity standpoint. Now, interestingly, if we bring this now to another therapy with the ide-cel therapy, which is the first approved CAR T cell therapy, we saw that with time there was an improvement. And this is, of course, reflective of the type of therapy this is, where people have a more intense therapy up front, but then ultimately with that one and done approach, they can come off treatment. And so here we look for, again, these measures of health-related quality of life, their global health status, their physical functioning, which we see improve over time after their initial treatment. But then we also, by contrast, look at the things that can be difficult for these patients, namely fatigue and pain. And we saw those go down in the KARMA study. And so that was very encouraging for us to see that, because we can be taken by the response rates we see with CAR T, but it's also good to know that this carries over into quality of life. And so similarly with cilta-cel, we have a similar data based on the CARTITUDE-1 study, where we saw that health-related quality of life, as we measured it with physical function and global health status, that did improve over time, and that there was also a reduction in their pain and fatigue over time. So that's really encouraging for us from that quality of life standpoint. Now, as I always say, a treatment is only as good as when people can get it, right? Almost like the old adage, if you don't take a temperature, the patient won't have a fever, right? If you don't have a treatment available to someone, it's not going to be of use to them. And so we know that unfortunately, there are so many factors that inhibit access to care, whether it's participation in clinical trials or even access to newer agents. Real world evidence is quite different than what we see published in the data in these clinical trials that we see, where patients unfortunately do have a reduced overall survival and reduced progression-free survival when compared to what we see in the trials. And this is a multifactorial problem. And I'm not going to be able to solve it and explain it all in a few minutes. But if we take CAR T as one example, there are multiple points along the way where we can see barriers. Right off the very start, as we've often discussed, that not all patients can be eligible for CAR T. There are patients who could have comorbidities and performance status such that they're not going to be able to have access to CAR T to begin with. There is quite a considerable cost here. And so insurance, as I'm going to come to in a moment, is one of the huge barriers of access to care. There may be patients whose disease is just not going to be amenable to this with that 4 or 5 week delay in getting the manufactured CAR T cells back. Often, even just getting to a CAR T cell center, if someone lives near one, that's one thing. But many of our myeloma patients live out in the community, in rural areas where they don't have access to it. And then, of course, some of the concern and fear about some of the very CAR T specific side effects, cytokine release syndrome and neurotoxicities, may be a barrier to begin with. And this emphasizes a critical point of the disparities that we see in multiple myeloma. We know that myeloma is twice as common in the African-American population, but we also know it's not just an incidence issue, it really is a survival issue. And so you can see from the data here, which is worrisome, that incidence is twice as high, but yet you see the death rate also being twice as high. So all of this great improvement in survival we've seen in myeloma has not been seen to the same degree in the African-American population. Black females are 2.6 times likely than white females to be diagnosed, and Black females are 2.3 times likely to die from myeloma than white females. Now, what is the cause of this disparity? There are multiple causes. There are often delays in diagnosis, and we know this happens generally in myeloma, but is more pronounced within the African-American community. A lot of it has to do with mistrust within the system. It has to do with insurance barriers to have the testing done. It has to do a lot with overlapping diagnostic considerations like diabetes that may be more common within the African-American population. But then access is huge. And as you see here, we often talk about those 4 T's. Triplets, transplants, trials, and now even CAR T, we have data emerging around less access. And we know that triplets have dramatically improved outcomes in myeloma, as have autologous stem cell transplants and indeed clinical trials and now CAR T. And so these things can reduce access for a whole host of reasons. Socioeconomic status is clearly related to mortality in multiple myeloma. So it's not just a pure access issue. We know that many of those other features, socioeconomically speaking, they're associated with more comorbidities and obviously types of insurance. And then, of course, just pure access to these precise therapies that we know make a difference. All of this forms this sort of rubric of unfortunate circumstances that leads to such disparity. And this is really just scratching the surface. There are many other disparities. So trying to bring this all together in what we've been discussing today about antibody drug conjugates, bispecific antibodies, and CAR T-cell therapies. These are all exciting new approaches to myeloma. For ADCs and bispecifics, we pretty much take them off the shelf, whereas CAR T requires that prolonged manufacturing time. From an administration standpoint, ADCs are relatively straightforward. In the outpatient setting, we give them IV. We're still sorting it out for bispecifics. Right now, patients do need to be admitted for their first dose or two, whereas, of course, CAR T-cell therapy is much more involved and requires often a significant inpatient period. The toxicities for ADCs are mostly quite managed with respect to the infusion reactions and cytopenias, but it's the ocular toxicity, that frequent keratopathy evaluation. Bispecifics seem to have a lighter version of CRS and cytopenias than CAR T, where obviously this is a critical feature early on, but eventually those patients, of course, can come off therapy. In ADCs, we're not really relying on a patient's own inherent T cells, but we are doing so for bispecifics and CAR T cell therapy. So I hope this kind of summary helps bring all the things we've discussed together.
Now we'd like to take a moment to discuss a lot of the points that was talked about, and very importantly so. And first I want to talk about the quality of life data, which might be a little bit immature, but how do we anticipate this evolving over time as we get more data from more studies? Joe, why don't you start?
So, Nina, I'm really glad that more and more of these studies are capturing this data, because it's critical. I mean, we might sort of intuitively think we know what they're going to show, but that's the whole point, is we want to have it objective. And so I actually think that this is a very important point going forward, especially now as myeloma patients are living longer, as we have more choices, as we're starting to experience toxicities that are kind of different from our historical, neuropathy, GI, and cytopenia-like toxicities, as we see different things. So I think prospectively collecting this data is important. But I'm also really feel that it's important that as a field, we evolve in our thinking to recognize how important quality of life is for patients. That yes, we use these defined and important measures, but every patient themselves defines quality of life the way they see it as purposeful. And so it's really a reminder to us as clinicians how important it is to have that ongoing dialogue with patients, to know, is this good for them? How are they doing with it? Not just what their numbers look like. As I say, all the time, I don't treat myeloma, I treat people. And so viewing them in that light becomes very, very important.
Yeah, I couldn't agree more. What do you think, Luciano? How do you think this data is going to evolve over time?
There's always the expectation that for CAR T cell being such an active therapy, but one that is very front loaded in terms of the toxicity, that the patient will have a fantastic quality of life. And we see that in clinic, as I think, Nina, I have seen you make this point many times. Patients suddenly are traveling again. When traveling is allowed, they are enjoying family. They don't have to plan their life around myeloma because their appointments are less frequent and so forth. With the bispecific is always going to have the hindrance on continuous therapy, which can be a blessing if that is important to maintain disease control, but also can be a hindrance. But unless the ADCs, they will have the problem with the keratopathy that we think might affect that long term. But like Joe said, so those things, we all have opinions, we all perceive that from our patients, but it's important that we get to measure those things to have a data-informed discussion.
Yeah, I'm looking forward not just to these primary sort of questionnaire outcomes, the QLQ-30, but the secondary subscales like emotional functioning, role functioning. These are the things I think about that make patients people. And we're doing a little bit more of that data gathering for these particular studies. So as Joe said, I'm very happy that this is part of, it's another set of data that we're looking at as far as outcomes go and efficacy. It's part of efficacy, really. Now, Joe, you brought up a really important point about access. And what do you think, what is being done to address access to CAR T therapy? And is this going to improve the access issues that we have?
I do see some light at the end of the tunnel, but I still think we're in a tunnel. There are going to still be a lot of supply chain issues and other challenges that make CAR T cell therapy in general less accessible to patients over the short term. In the long term, I think many of those logistical-like things and supply chain-like things will get better. But as I mentioned, there are so many other access barriers that are not so easily fixed as a supply chain. There are systemic mistrust issues. There are socioeconomic issues. There are geographical issues. And sometimes CAR T even exacerbates that because CAR T cell centers are often not located in the very places where many minority populations might live or have access to. And so that can be a problem. So we have to see that there are some short-term issues that hopefully we can address in the short term and correct. But then there are longer-term and systemic issues that require a lot more attention. And thankfully, I really do feel that the cancer community is starting to recognize more and more importance of health equity and the inequities that exist and how unacceptable they are. And in particular, myeloma, as we've commented about the incidence of myeloma being twice as high in a younger population, the African-American population, the Hispanic population. And so these are issues that we need to address over the longer term. And I believe we're beginning to address them, but it is going to take us a long time to reverse many of these challenging access issues.
Yeah, that's really well put. Luciano, do you see the access being an issue for bispecifics?
That's a great question. I think at first it might be, particularly as it gets linked to that hospitalization. We all know, and that's more on the headlines than ever, that our hospitals usually run at full capacity. So it might be a little bit of a hindrance, but as time goes by and we develop strategies to administer that in outpatient basis, I think the access is going to be not a major issue like it is now with CAR T cell. It's going to be also not less of an issue than it is for any advanced, expensive myeloma drug. You still have the problems with affordability, insurance, and all this and the other. But I think the scalability of bispecifics, it's so much higher than with CAR T cell, and I think that is really the greatest, great appeal.
Yeah, and we were talking about this, but you think they're probably going to have a REMS for bispecifics as well, right?
I'm pretty sure there will be.
Yeah. So Joe, you talked a lot about the 4 Ts, and it's just impossible to answer in 1 minute, but what do you think is the most important thing being done to address the disparities in care for myeloma and the disparities for these 4 Ts?
Well, Nina, you've hit on a topic that is obviously one of my great passion, and it's difficult to answer because there are so many features to it. But the first way I think about it is, if we're going to help overcome these 4 T challenges, which are so important to us and remind us of the inequity we're dealing with, first of all, it's going to take multiple stakeholders. So it's going to take those in the regulatory side, in industry, within healthcare, and then within, if you will, the non-medical community, and of course within the patient lay community. Everyone plays a role in the solution. And the first step in any of it, of course, is to recognize the magnitude of the problem, which I think society is starting to do. There have been movements and things that have pushed us in this direction, but there's a lot of health disparity research going on. I would say that 80 to 90% of it is all diagnosing the problem, which is fine. As doctors, we want to diagnose first and treat later, but we need to then ultimately start having very concrete solutions. In the myeloma sphere, specifically in these 4 Ts, as we know, there are multiple factors involved with it, and we can address them individually. I think there's one strategy for clinical trials, which is a little bit different than the strategy for, let's say, transplants or even for triplets. On the level of triplets, a lot of that has to do with the relationships that we have within the community between the myeloma treaters and the patients, but also in the insurance world. And have we really leveraged every system possible? And so, the work that I do with the International Myeloma Foundation, we're committed to this. And so we work within the community and finding ways and solutions, building trust, working with the medical, non-medical community to build up the community and lay side of it, and even to help educate docs about cultural competence and things that we can do day by day in the clinic that can help move this needle further in the right direction. As well as at the same time, as I mentioned, the other stakeholders, the FDA, the industry, others who are involved with it being committed to this issue, so that if in a disease like myeloma, where 20% of all myeloma patients are African-American, but they're only represented 4, 5, 6% of clinical trials, that's not acceptable anymore.
Yeah, I agree. So just to summarize, for BCMA targeted therapies, they have unique adverse effect profiles. We know that current BCMA targeted therapies have an adverse effect profile that requires intensive monitoring, prevention strategies, as well as specialty care to manage the toxicities, and REMS program in place for participation. But despite these AEs, the health-related quality of life continues to improve, or at least remain stable. Now, we know that coordinated efforts are needed to improve access to care. This involves addressing things like healthcare disparities, geographic distance, cellular therapy center capacity, efficient referral, and insurance approval process. For bispecific antibodies, they may cause less severe CRS and ICANS, and this may ultimately allow for broader use in less specialized settings. And with that, I wanted to say thank you for participating in this activity and joining us today. Make sure you claim your CME credits by completing the post-test and evaluation form, which can be found on the links in the tweets and the comments below. And make sure to follow BMCA on Twitter to stay tuned for more multiple myeloma content.